Dr. Hutner is a Harvard and Columbia trained psychiatrist, entrepreneur, and educator in the emerging medical specialty of reproductive psychiatry and women's mental health. Dr. Hutner earned her MD degree from the University of California, San Francisco, and she completed adult psychiatry residency training at Harvard at Massachusetts General Hospital, McLean, where she was one of the chief residents. She then completed a 2-year consultation-liaison fellowship at Columbia University. Dr. Hutner was the associate director of the first comprehensive women's mental health program at Columbia University Medical Center and was one of the associate residency training directors at NYU. She is on the leadership team of the National Task Force for Women's Reproductive Mental Health, which launched the first standardized digital curriculum in reproductive psychiatry in the fall of 2020. She is a lead editor of the first ever textbook of reproductive psychiatry, Textbook of Women's Reproductive Mental Health, which was published by the American Psychiatric Association in 2021. She co-leads a national multidisciplinary task force creating the first dedicated mental health digital curriculum for obstetric providers. Dr. Hutner is a co-founder and chief medical advisor for the digital startup Phoebe, which provides a roadmap and safety net for women in late pregnancy through postpartum. And she's a consultant and strategic advisor for Gemma, a digital education resource for women's mental health, centering diversity, equity, and impact. She continues to supervise and teach residents at NYU, and she is a first-year analytic candidate at Columbia Center for Psychoanalytic Training and Research. She maintains a private practice in Manhattan. Dr. Hutner, thank you so much for joining us today. We look forward to your presentation.
Thank you so much, and I am really delighted to talk to you all today. Thank you so much for that introduction, and it's great to be able to get a chance to talk about my favorite topic, which is women's mental health and reproductive psychiatry. So I'm going to go ahead and share my screen here. Can everyone see the screen?
Yes.
Okay. Okay, great. So what I thought I would do today is, I'm a clinician first. I am assuming that a bunch of you are also clinicians. However, I'm actually delighted that UNM has a reproductive psychiatry fellowship, because it's actually quite rare in the United States. There are only about 18 fellowships throughout the continental US. So yeah, yay, Marquette. It's actually really, really, really wonderful that you all have a fellowship. And one of the reasons why I feel so strongly about that is because then you're able to develop resources around reproductive psychiatry within your institution. So congratulations, that is really fantastic. And what I'm going to do today is talk a little bit about a clinical overview of what are some of the major things that we think about as reproductive psychiatrists. And because there are so many different potential ways that we could approach this topic, I thought today I would focus on the postpartum period with the questions of, hey, what are the things that we really think about from a clinical perspective as we have patients who are approaching or who are in the postpartum period? So again, I teach at NYU. These are my disclosures for both Phoebe as with Gemma, and royalties from the textbook of Women's Reproductive Mental Health. So the first thing I would say is that we all understand in a wonderful way that over the last, I would say 10 to 15 years, the whole entire concept of what happens to women and birthing people as they give birth and enter the postpartum period, it has sort of not just been a focus of clinical attention, but it's actually entered the wider culture. This is a picture of Cardi B after she gave birth, and she was very forthright in the media about the postpartum depression that she experienced after she had her daughter. I would say that this is actually very different from even 10 or 12 years ago when I was a fellow at Columbia, where, people were still not really talking about the postpartum period and postpartum depression in particular in the wider culture at all. It was still very stigmatized and sort of still somewhat something that people sort of didn't really discuss. Now, the difficulty is that one of the things that's sort of been a wonderful outcome of all of this discussion in the culture is that there's a lot of discussion about it. The only difficulty is I cannot tell you how many times I've had patients who say something like, I'm actually kind of terrified now of the postpartum period. I had a patient actually just this morning say, I feel like I'm preparing for war because there's a sort of sense of, oh my gosh, I'm about to get postpartum depression because I've had depression before, or they hear about very catastrophic outcomes that are in the media and they think to themselves, oh my God, that's going to be me. So one of the things that I think about a lot with my patients, and we sort of think about from research and a clinical perspective, is sort of not just how to manage issues in the postpartum period, but actually even mitigate some of the risk factors and take a look at even issues around prevention. I actually think that I try to really get my patients away from this idea that they're preparing for war, because I've had many patients who've actually done quite well in the postpartum period, even if they're fairly high risk, because we've been able to mitigate some important risk factors. And why do we think about the postpartum period so much generally? I mean, first of all, it's an enormous transition. This transition in someone's life, especially when they give birth for the first time, is generally considered one of the most significant transitions, as well as a very strong transformational period in someone's life. It also corresponds, however, with a significant mental health vulnerability. So if you look at preconception, first trimester, second trimester, third trimester, and the postpartum period is clearly the time of highest mental health vulnerability. So for example, we all might be very familiar with the data that says that postpartum depression is the most common complication of childbirth. Pre-pandemic, that prevalence was about 15 to 20%. Actually, during the last years of the main part of the COVID pandemic, sort of 2020 and 2021, that prevalence rose to 35%. So you can actually see that some of these variables actually vary quite a bit in terms of social context. The other issue is that there's a lot of associated factors that I'm going to get into later in the talk about why the postpartum period can be such a vulnerable time. I'm going to speak a little bit about systemic issues and social context factors, as well as some individual factors that may play another role in the postpartum period. So when we think of postpartum, I laugh a little bit when people talk about the first 12 weeks after delivery. In the DSM, the postpartum period, and in most early research, the postpartum period was considered the first 3 months postpartum. I think that is just a wild underestimate for the magnitude of the changes that are going on in the postpartum period. I think most of us as reproductive psychiatrists consider the postpartum period generally the first year postpartum. It is a crucial time for the birthing parent and their family and their loved ones. It's often called the fourth trimester for that reason, because it's a very, very salient time for the birthing parent and their loved ones. And in some ways, if we think about it in a positive direction, it's a critical period that actually can set the stage for long-term health and well-being. But it's a significant challenge because the person who is giving birth is going through a number of physical, mental health, emotional, relationship changes, and yet they're also doing it all at the same time. So for example, in the postpartum period, the overall levels of estrogen and progesterone, which have been at the maximum peak at late pregnancy, those levels actually dip to basically menopausal levels within the first 24 hours after giving birth. We understand as psychiatrists that our brain reacts to not just changes in various hormones and other things that affect our brain's functioning, but our brain strongly reacts to the rate of change. the rate of change of hormonal effects of the brain are very profound in the immediate postpartum period. And many people actually are particularly sensitive to this. Interestingly, it's not everybody. So for example, it's about 25% of all people who give birth who are particularly sensitive to the hormonal changes after birth. And this is one thing that I tend to emphasize with a lot of people, because a lot of people sort of think, oh my God, I'm going through so many hormonal changes. Of course, I'm going to react to that. And of course, I'm going to have postpartum depression. And that's actually not necessarily true. You can actually identify people who tend to be at higher risk from these hormonal changes, partially because they tend to be sensitive to all other forms of hormonal transition in their life. These are the people who have quite significant PMS or even going into PMDD. These are people who might have felt quite depressed when they were placed on birth control. I've had a number of patients who undergo IVF, and when they get the progesterone supplementation, that induces a fairly significant mood change. These are people who have, over the reproductive lifespan, have sort of demonstrated a particular sensitivity to those changes. But it's not just hormonal, of course. We understand as physicians that this is a period of time of immense immune system changes, metabolic changes, and then, of course, the person has to recover from either a vaginal delivery or a cesarean. Of course, at the same time this is going on, you're experiencing a very significant change in family roles and responsibilities. I actually just spoke to a patient and her partner this morning, and they're like, she's about 37 weeks now. And she said, oh my God, I finally just stopped thinking about being pregnant and realized that we're bringing a baby home in about 3 weeks. And that is just about the time that people start to realize that they're going to be taking care of a newborn and an infant primarily on their own. There's also significant sleep deprivation. And this is something I talk about a lot with my patients in the postpartum period, all while they're actually trying to keep a baby alive and nourish them and feed them. Feeding is another important thing that I will get to later in the talk. And then looking out for mental health conditions. And again, the postpartum period, unfortunately, is considered the highest risk time of mental health vulnerability, including the development or exacerbation of psychiatric disorders. And again, it's a very complex interplay of biologic factors, psychologic factors, and social factors, in not just the underlying genetic and environmental contributions. The other thing to keep in mind, and I think that we as psychiatrists, I think, have been doing a little bit of a better job of getting this message out lately, is that it's actually not just postpartum depression that we have to think about. Postpartum, perinatal and postpartum anxiety, or perinatal anxiety, is actually perhaps even more prevalent and may in fact be more impactful even than perinatal depression, although these are intermingled about 80% of the time. We really want to keep our eye on any pre-existing or newly developing mood disorder, particularly with the affective psychosis, postpartum psychosis, which, although it is rare, occurring in about 1 in 2,000, 1 in 3,000 births, it does carry a risk of suicide and infanticide, even though both of those outcomes are rare as well. Obsessive compulsive disorder, which about 20% of all patients with OCD actually were diagnosed in the postpartum period. So the postpartum period is a particularly vulnerable time for OCD. Post-traumatic stress disorder, either pre-existing or secondary to birth trauma. And then eating disorders. Eating disorders is an interesting subject, because actually many people with eating disorders during the pregnancy itself can sort of mitigate the eating disorder behavior because they're sort of feeding somebody else. But then as soon as the baby is delivered, those eating disorders tend to flare again. Something is not mentioned here, but is very important, and sometimes hidden under the cloak of stigma, are also substance use disorders, which are very important to recognize and to treat in the perinatal period. So first thing that I thought I would do is think about, if you're a clinician, you're a general psychiatrist, You may have heard a little bit about the postpartum period, a little bit about what to look out for. But then the crucial question becomes, okay, if you have a patient in your practice or a patient in the clinic, how do we really know when someone is experiencing a true psychiatric emergency? And how do we know when someone is actually able to be perhaps treated as an outpatient? And what do we do to think about that? So I'm going to give an example here, and I just sort of think it through with you because there are some important facets of what we think about, particularly in the postpartum period. So this is an example of a woman, Sybil. She's 27 years old, G1P1, and she is 11 days postpartum. Most mood disorders, if they have their onset in the postpartum period, are going to occur within 4 weeks postpartum. They don't typically arise immediately after birth in the first sort of 1 to 2 days, although you can sometimes see some prodromal symptoms then, but generally within the first 4 weeks postpartum. So this woman is 11 days postpartum. She doesn't have a formal past psychiatric history, but her husband reports that she's somewhat anxious at baseline. And her mother calls your office because she's seeking an urgent evaluation for her daughter. The husband accompanies the patient to the appointment, and you can immediately recognize that she seems to be behaving oddly per the story from the mother and the husband. She is clearly not sleeping, and for the husband, the patient has been very anxious about which tasks have been carried out appropriately. Now, if we just think about this situation and we say, okay, where might there be an emergency here? The major thing that I would think about in this moment is the fact that she has not been sleeping. Now, the problem is many people do not sleep in the postpartum period, right? It depends on how the infant is being fed. It also depends on the level of social support. So it's not that, that everybody sleeps in the postpartum period and then you just have a few people with affective illness that are not sleeping. This is a crucial question, and it's one of the things that you want to keep your eye on. And the second thing I would say is the issue about anxiety, because anxiety in the postpartum period can be very hard to figure out. And I'll walk you through a bit of an algorithm here, but it can be very hard to figure out, is this normal worry, which happens to virtually all new parents? Is this, and especially because pregnancy significantly changes the brain and sort of hyperactivates some hypervigilant circuits in the brain. And so because of that, normal worry is very, very, very common. Is this some sort of obsessional anxiety? Is this someone who just has a sort of higher rate of perinatal anxiety and they're just sort of like worried about everything, and it might be a little bit more than normal worry, but it's getting flared up? Or is this riding along with some sort of mood disorder and some sort of real psychiatric emergency here? And again, it's a little bit hard to tell from the very beginning because the husband reports that the patient is leaving notes all over the house on how to do things. Not that uncommon, right? You can sort of imagine someone who's sort of wanting to have people support. They're trying to keep track of bottles. They're trying to keep track of formula. And it wouldn't be all that unusual for someone to leave notes all over the house, except that she seemed confused. He found the iron in the refrigerator yesterday. And probably more concerningly, for the last 2 days, the patient has been unwilling to let anyone else hold the baby. She explains to her husband that only she has the appropriate knowledge to take care of the child. But again, you can kind of see a way where sometimes people just feel that way a little bit. Sometimes they feel very careful about who holds the baby, especially in COVID times. People are very worried about who comes over. So again, it can be really hard to sort of suss out some of these symptoms. The husband has found the patient standing over the crib for long periods of time while the baby is sleeping. And he notices that his wife appears to fear windows. She pulled down all the shades. And yesterday she was seen standing by the open window, holding the baby and looking confused. So this is a situation where we are starting to get a little bit more concerned clinically as you go through this, especially because on mental status exam, the patient's mildly disheveled. She has poor eye contact. She is tangential, rapid, and disjointed. She's clinging tightly to the baby. And again, the mental status exam is getting more and more concerning. She is darting suspicious glances at her husband and is concerned that her husband will harm the baby. When asked how or why, the patient says that the husband had gonorrhea several years ago, and she's concerned that somehow that he is spreading this infection to them. So again, it is not that uncommon for people to have obsessional type of anxiety in the postpartum period. And when people have obsessional type of anxiety in the postpartum period, the two major types of fears that they have are fears coming to some sort of harm coming to the baby or contamination fears. However, so this is a sort of contamination type of anxiety here, but you can see that it's not quite reality-based. He had an infection several years ago. It's a sexually transmitted infection. There doesn't appear to be any reason why that would be the case now. However, she's very concerned about this type of infection happening to the baby. So a little bit disconnected from a realistic anxiety. So on our differential, the main thing that we're going to be thinking about is this some sort of obsessive compulsive disorder? Again, contamination fears. Is there some sort of fear of windows, which would be, to be honest, a fairly unusual fear? Again, the major obsessions that people have in the postpartum period are harm to the baby and contamination fears. However, she is having some symptoms that make us a little bit worried about whether she's having postpartum psychosis. She has an idea that about her child, that only she can hold the baby. The husband is an enemy. Nobody else can be trusted to care for this baby. Something about a window, which is also quite concerning. This case is based on a patient that I saw about 4 or 5 years ago. And it was very hard to tell, number one, because obviously patients who are in this situation are very guarded for the most part, but also they may be sort of aware at a certain level that they're not really supposed to be mentioning some of these symptoms, especially if there is low trust between her and the clinician. But also because some of these symptoms can really sound quite similar. And again, if someone is having something that sounds like a contamination obsession, you could get a little bit confused about whether this is postpartum psychosis or obsessive compulsive disorder. But what are the other concerning signs? Number one, the iron in the refrigerator would be a concerning sign because postpartum psychosis can often have a delirium type of presentation. The person can just seem actually quite confused, and they are certainly behaving in a way that is not consistent with how they usually behave. And clearly the lack of sleep is a really important factor. And one of the ways that you can differentiate this, sometimes people will try to ask the question like, do you sleep when the baby sleeps? And the truth is that most postpartum people do not sleep when the baby sleeps. That is just, most postpartum people are trying to clean, or they're trying to fix the bottles, or they're trying to take a shower. They are trying to finally get some things done when the baby is sleeping. I think the more traditional way of how we try to elicit any type of hypomanic or manic symptoms with regard to sleep is actually a better way of thinking about this. Sort of this idea of it's impossible to sleep. I feel like I don't need to sleep. Patients will report feeling very wired, feeling like they're revved up. I've had a number of patients say, like, I just feel like I took like a ton of Red Bulls. I just feel like no matter what I do, my body is buzzing and I just can't turn this down. Interestingly, this is also sometimes a very early symptom. You can sometimes see the sleep difficulties emerging quite early, and then the other symptoms start to follow from that, very similar to what we see in bipolar disorder. And obviously her mental status exam with a rapid tangential speech is very concerning. And so the things that we really want to ask, obviously, is we're trying to figure out, to what degree is this an emergency? And I think all of us immediately would recognize that this is clearly starting to look like a psychiatric emergency. We really want to think about how to carefully ask about thoughts of harm to baby and self. Why, what is she actually particularly concerned about with the windows, special powers, unusual beliefs? Why can't anyone else care for this baby? Why is she watching the baby? And why is she not sleeping? Now, we all understand as psychiatrists, like the chance that we're going to get very direct, linear, cogent, and fulsome replies to all of these questions, I think is probably somewhat unrealistic. I think a lot of times what we want to do in the postpartum period, especially when someone presents with this sort of a little bit of a confusing picture, but a concerning one, you sort of want to try to do a couple of things. You want to take the situation in aggregate. You want to think to yourself, what is the patient's mother saying? What is the husband saying? What does she seem like on mental status exam? Sometimes what I do too is I actually, instead of really honing in on these very direct questions, I might actually take a sort of sideways approach and try to see if I can calmly and non-judgmentally get the patient to speak a little bit in her own words about what's happening, and try to see if I can open up the story a little bit, and paying attention to the tangentiality, the lack of reality testing. Those are the sorts of things that would pull me. And then it's only really as I get to the end of the interview that I might hone in on some of these specifics. And I would probably hone in on the most mild and least threatening ones first. Why does the person believe that no one else can hold the baby, right? Like I would probably start with something like that. And then I would, if I have time and if I'm able to keep the patient contained in the interview, then follow it up with some of the more focused questions. Clearly, this person is exhibiting some very concerning signs of postpartum psychosis. She knows that the baby is special, that she herself has been appointed to protect the purity of the baby's soul, that if anything threatens that purity, death of the baby is preferable to impure life. She put down the window shades because she didn't want to have impure people staring at the baby. But just in case some sort of impurity occurred, she's now opened one window at the back of the house, and she's not sleeping at all, and she feels full of energy, and she's not tired at all. So clearly this is someone who we are worried much less about some sort of clearly normal worry. We are not necessarily concerned about a general perinatal anxiety. I'm still considering a little bit of postpartum OCD, which can really sound a lot like postpartum psychosis a fair amount of the time. But what you're concerned about the most in terms of this emergent situation is postpartum psychosis. You want to ask specifically about thoughts of harm to the baby or self. Again, trying to normalize this in the most non-judgmental way possible. And again, this is really, really important because since postpartum psychosis is relatively rare, I haven't had all that many patients in my practice with postpartum psychosis, but it's happened a fair amount. And out of the group of patients that I've seen, probably half of them, shockingly, actually got through the postpartum psychosis period alone with no support because they were so terrified to go to a psychiatrist that they actually didn't see anybody at all. And when it was only when it's shocking. I mean, when I first met patients like this, when it happened once, I was like, this can't be right, that this person actually suffered with these symptoms by herself, not really telling anybody, and just sort of waited until it subsided. She then came because she was nervous about what would happen with her second baby. So about 1.5 years later, when she was considering a pregnancy again, she then finally went to see a psychiatrist. I've had a patient, I think that's probably happened about 10 or 15 times now. And I think that, again, the sense of stigma, shame, guardedness, and also real concerns about whether the baby is going to be taken away or Child Protective Services is going to be called, or frankly, if you're going to hospitalize them and separate them from the baby, this is, there's a lot of reasons why people don't quite tell the full story when you're evaluating them. And so we want to try to normalize this and ask the questions in as non-judgmental as a way of possible. And crucially, one of the things that we want to do too is get a sense of whether these thoughts are ego-syntonic or ego-dystonic. And we understand as psychiatrists, right? If someone has OCD in the postpartum period, those symptoms are ego-dystonic. The person will say, I cannot, I've had a lot of patients with postpartum OCD, and they will say, I cannot for the life of me stop thinking about the germs that are on that bottle. I am convinced about something to do with the germs or the BPA or something, some sort of lead poisoning, something to do with contamination. And then they will say, I know I'm crazy, but I can't stop thinking about it. These people have insight. They don't have, obviously, the sleep issues and other things that are going on with an affective psychosis. But the main thing they will say is, I know it doesn't make sense. I know that it's okay to use this bottle. I know that my baby is safe. I can watch them breathing. I just can't stop this never-ending cycle of thoughts in my head. Now, one thing I will say about postpartum OCD, it can be very severe. And I have had a number of patients that I have either sent to the ER or nearly hospitalized. I actually hospitalized one patient where they actually didn't have postpartum psychosis, but their obsessions were so severe and so disabling that they were at that point completely incapacitated. And their inability to turn off their obsessive anxiety can be very disabling. And so it's not that OCD cannot be severe, because it really can be severe in the postpartum period. It just doesn't, fortunately, carry to the same degree of suicide or infanticide risk that postpartum psychosis does. And then you want to clearly ask about other psychotic symptoms, other avoidance behaviors. And clearly, the major question is, can this person leave the office? And thinking about the level of obsessions, ego-dystonic versus ego-syntonic. A person with postpartum psychosis will clearly believe that the bottle is contaminated, that no one else can care for the baby, that some sort of terrible harm is going to come, or that they need to save the baby by harming them because in answer to a greater harm that might come. These are ego-syntonic. It is delusional. The person does not have insight into their symptoms. Again, sometimes these symptoms can wax and wane a little bit with postpartum psychosis. So sometimes the delusional behavior and the delusional thoughts are not quite as strong, but they are typically remain ego-syntonic. Ego-syntonic. You also want to talk about an intent and plan, but again, I would take, it's not that I don't believe patients who say that they're not suicidal or have thoughts of harming to the baby, but I would take the whole entire context into account when I think about the level of risk. And again, postpartum psychosis is a true psychiatric emergency. And bottom line, we're going to be immediately sending this patient to the emergency room. And the reason why is because she's clearly ego-syntonic beliefs. This is a psychiatric emergency. And the reason why I even go through this in detail is because it's really hard to hospitalize a new parent, and there is a tremendous scarcity of mother-baby units in the United States. What that means is a hospital's ability to have the baby along with the new parent when they're in an inpatient psychiatric unit. There is one at Brown. There is one at University of North Carolina. There is a partial hospitalization program in New York City called the Motherhood Center, but it is exceedingly rare to have a mother-baby postpartum unit. So most of the time, and the reason why I went through this whole evaluation process in detail is most of the time, psychiatrically admitting someone does mean separation from the baby with all of the physical, logistic, emotional, and social ramifications of that decision. However, obviously safety trumps all. The risk of suicide with a patient with postpartum psychosis is 4%, and the risk of infanticide is about 2 to 3%. Suicide, unfortunately, is high in the postpartum period in some countries, including the United States. Suicide and accidental overdose are the leading cause of death in the first year postpartum. Also, we want to take a look at the infanticide risk clearly with about a risk of about 2 to 3% in postpartum psychosis. However, sometimes patients will present in a highly agitated state, and it's not just that they have either postpartum OCD or postpartum psychosis. Some of the time, of course, we want to keep in mind, is this person in some sort of withdrawal? Did they abruptly discontinue psychiatric medications? Are they in some sort of alcohol withdrawal or some sort of other substance abuse? This is just a sort of quick look at how we sort of handle psychiatric emergencies or how we handle acute presentations in the postpartum period. So what we would consider a sort of non-urgent situation, but something we definitely want to follow up on is, someone who presents with clear postpartum depression or anxiety. This slide says able to contract for safety. I don't ever do safety contracts. I don't think that they're evidence-based, and it's hard to tell what utility they have. But someone who clearly does not appear to have significant risk for suicide is someone that is probably okay for outpatient care, that they have a reliable system for follow-up, that the person appears to be adherent to medications, etc. In general, that is someone who can be seen routinely as an outpatient. The other thing too is that it is, even before the pandemic happened, there was quite a bit of evidence supporting the use of telemedicine in the postpartum period. So even though so many of us have gone to telepsychiatry, in fact, we as women's mental health specialists were a little bit ahead of the curve in the sense that many people in the postpartum period, right, they can barely take a shower, or they're recovering from a C-section, or they just simply don't have the time or the wherewithal to make it over to your office. Kathy Wisner and some other people at Northwestern actually have done quite a lot of studies looking at the utility and the effectiveness of telepsychiatry in the postpartum period, and it actually is effective. And so we feel pretty good about following people, stable patients, as an outpatient that way. Urgent patients would be patients who are expressing some passive suicidal ideation, but without a plan. Someone who has some degree of alcohol or substance abuse, but they are not appearing to be in obvious withdrawal. They're not delirious. They're not having altered mental status, or a pregnant patient who was requesting a detox. And then patients who obviously would meet the criteria for emergency care would be someone who is acutely suicidal, in acute withdrawal, or otherwise having a strong alteration in their mental status, having any thoughts of harming the baby or anyone else, but anyone who is very agitated. There are a number of reasons why medically someone would with a high degree of agitation in the postpartum state, including things like a hemorrhagic stroke, a pulmonary embolism. There are all sorts of reasons why someone could present in a very agitated way, and that person should always be seen in an emergency setting, postpartum psychosis, and delirium. And just some tips if you happen to be managing someone who is quite agitated in the emergency room. In pregnancy, we want to see, but even in the postpartum period, particularly if someone is breastfeeding, we want to see what we can do with verbal de-escalation. And that is because, we obviously want to always try that first. But again, patients who are pregnant are often somewhat reluctant to take medications, or they may be somewhat reluctant or very reluctant to take medications. When someone is breastfeeding, they may be reluctant to take medications. Something that I always try to emphasize to patients is that taking a medication while breastfeeding is a very different idea than taking a medication while someone is pregnant. We understand that most psychiatric medications actually have a either quite reassuring or very reassuring profile, even in pregnancy itself. But that is even more true in the postpartum period with breastfeeding, because most psychiatric medications, with the exception of a few like lithium, and very long-acting antidepressants like Prozac has a little bit of elevated rate of transmission, but most psychiatric medications actually don't prefer to pass through the breast milk and actually have a fairly low rate of transmission in the breast milk. But most people don't know that. And so some form of psychoeducation and really trying to reassure the patient can be helpful. You also want to suit the medication to the symptoms, right? Sometimes a little bit of Ativan for a highly anxious or a patient that you're worried about is in withdrawal for agitation is obviously more beneficial than necessarily simply giving them a high potency typical antipsychotic. There are good safety data now on second generation antipsychotics. People used to always give in pregnancy and even in the postpartum period, they tended to go to Haldol, although using Seroquel or perhaps some Zyprexa, those actually have a very reasonable safety profile now as well. Higher doses may be needed in pregnancy, but in the postpartum period, that's actually the reverse. So one of the reasons why that's the case is because in pregnancy, starting in about the mid to late second trimester, metabolism starts to increase, and that continues to increase until very late in the third trimester, about week 34, 35. And because of that, there was actually a recent study that just came out that showed that, and I can send it along if anyone has interest, as the metabolism goes up in pregnancy, you can actually watch as the levels of medication start to go down. This particular study was done with sertraline, and you can actually look at the sertraline blood level, and it's going down and down and down as the metabolism is going up and up and up. So it's not surprising that you may require higher doses in pregnancy. And then in the postpartum period, actually the body needs some time to recover, and evolution has allowed the body to actually reduce metabolism in the postpartum period. And the same doses that you may have been on may actually be adequate in the postpartum period. You may actually need lower doses in the postpartum period. I actually have a patient right now who's about 37 weeks. She's actually the patient I saw today. Very high risk patient, has been hospitalized numerous times, ECT. She is on Lamictal, Klonopin. I was on some Seroquel, pretty high risk bipolar 2 patient. And she really struggled with this issue because she was already on Lamictal 400 milligrams going into pregnancy. And by the time she reached week 28, her body was clearly outstripping the Lamictal. And at that point, we actually got a Lamictal level. I didn't actually have to raise the Lamictal, but sometimes you really do have to raise certain doses of medications in the second trimester going into the third trimester. And then as soon as she got into late third trimester, week 36, 37, you can actually see the medications taking more effect because the metabolism is starting to lower a little bit. And again, we want to try and minimize exposures in a pregnant or postpartum patient as best as we can. But the truth is that frank psychosis in a highly agitated patient are also an exposure. We do a risk analysis, but these are not neutral outcomes. It's not just a decision of whether or not to take a medication. It's measuring the risk of a medication against the risk of what would happen if this person remained having untreated mental illness. We want to, and this is an uncommon outcome, but you may see this at times in the emergency setting. You always want to try and see if you can avoid restraint use in a pregnant, particularly in a pregnant patient, due to the risks of inferior vena cava syndrome, particularly if the patient is supine. If they need restraint, you want to put them on one side so that, again, the inferior vena cava is not risking compression. But again, I'm just going to these are some acute issues in the postpartum period, but these are not the only factors when we think about the postpartum period generally, because if we take a big step back, and I'm going to switch gears for a second here, we take a big step back, we think to ourselves, okay, is this an emergency? And if it is an emergency, we're going to handle it as an emergency situation. Is there a mental health issue going on? Okay, then we want to handle that mental health issue as best as we can. But one of the most crucial parts of being a reproductive psychiatrist is understanding that all of women's mental health and reproductive psychiatry occurs in a social context. And that becomes, I would actually go so far as to say that I think it's impossible to separate reproductive psychiatry from its social context, from the systemic issues that affect birthing parents, women, and their loved ones, and then also including individual factors that are not just about mental health, but are about sleep and infant feeding. These actually become very, very, very important in the postpartum period. And this is the last part of my talk because I want to hold some time for questions. But I just wanted to point out that, even though the postpartum period is a time of significant mental health vulnerability, the difficulty is that a fragmented and frankly deeply inequitable system of physical and mental health care fails women in birthing people just at the time that they're in the most need of a robust social safety net. And the truth is that the vast majority of pregnant women with mental health or substance abuse issues go untreated, and healthcare disparities in particular greatly impact perinatal care. I don't know if folks saw the news that just came out this week that said that in 2021, maternal mortality rates skyrocketed to rates not seen since 1965. It was a 40-year high in maternal mortality. And this really gets to major issues about how we need to systematically care for these patients. This is not an individual issue. This is a systems issue. Healthcare disparities include lack of access. And it's wonderful that we have major national organizations, ACOG, the American Psychiatric Association, the Task Force on Preventative Services, all recommend screening throughout the perinatal period, which is fantastic. However, positive screens need to be matched with resources. And there is a really significant lack of resources. I would love to hear about what it's like in New Mexico, but there are geographic disparities. There are issues around insurance. There are some solutions being offered. So there's a lot of work looking at integrated mental health services. So mental health services within obstetric clinics. There's a program called the Massachusetts Child Psychiatry Access Programs for Moms, which is mental health consultations and support. That's available in about 25 states. So there is a significant set of work looking at increasing the social safety net for women and their loved ones who are giving birth. I do want to point out, though, however, there are really significant racial and ethnic disparities as well. So, for example, the maternal mortality rate among Black women as compared to other ethnic groups and compared to white women is about 3 to 5 times higher in Black women than other groups, as well as higher rates of preterm birth, low birth weight, and infant mortality. And the other thing that, the other issue that we look at in terms of mental health in the postpartum period, systems issues in the postpartum period, we really want to look at postpartum sleep. And I've sort of gotten this little like nickname, I suppose, because all my patients understand that I'm completely obsessed with sleep. But postpartum sleep deprivation is common. It increases the risk of psychiatric illness. And it's often the most critical self-care issue that a new parent faces. And it's actually arguably the most important modifiable risk factor for postpartum psychiatric disorders. This is actually one of the main reasons why social support is so incredibly important, because if someone has the ability and the luxury to have not just them taking care of their baby, but a partner who might be available, some family members who might be available, some caregivers who might be available. This actually makes a huge difference in terms of the amount of sleep that the birthing parent can get, which has a direct relationship to their mental health in the postpartum period. But again, this is then related to issues around feeding, because sleep and feeding, which are the two main activities in the immediate postpartum period, are intertwined. Many people, of course, breastfeeding has clear health benefits in terms of infant mortality, in terms of reducing infections, and in terms of reductions in childhood obesity. However, this has to be balanced against the fact that there can be really significant challenges for women with psychiatric illness who breastfeed. This includes lactation and nursing difficulties, sleep deprivation. Again, sleep and feeding are intertwined. Stress and uncertainty, perhaps a history of physical sexual trauma, which leads to issues around birth, delivery, and feeding. And then fears again about medication exposure. So what I'm trying to indicate here is that the postpartum period is actually a matrix of mental health vulnerability, social systems issues, sleep, and feeding. Those are the main four things that you really want to look at in the postpartum period. And these are the things that we want to intervene on both an individual level for our patients as well as a systems level. And I will stop it here. Here are some resources, but I'll go ahead and stop sharing, and I can always share these slides. Just wondering if there are any questions from the group.
I have a question.
Yeah.
Hi, Dr. Hutner. Nice to meet you. Thank you so much for that wonderful presentation. I actually had a question kind of about the sleep. I know sometimes our medications in psychiatry can be sedating, and so birthing parents might be afraid to be put on medications that are sedating when you want to be able to hear the baby. And so just kind of wondering how you approach that.
Yes. So that is a really good question. The question is what to do about sleep and giving someone a medication in the postpartum period, especially because the person wants to be sort of awake when they and to potentially hear the baby. The first thing I ask is if it's possible for the new parents to actually, if they can, fully trade off. What I mean by that is in order to get some degree of adequate sleep, it's ideal if, say, for example, the birthing parent feeds the baby and they put the baby down at 7 p.m. In an ideal situation, they would then go to sleep, and then the other person who is caring for the baby would then take the first time the baby wakes up. And so that this person can continue to sleep for about 5 or even maybe 6 hours. This isn't an ideal situation and doesn't really work with exclusive breastfeeding. But if there can be someone else who is there, who is also available to wake up and take care and have their eye on the baby, that's number one. Because, and again, we can immediately see that the issues around social support are even right there with that question. The second thing that I do is I try to really emphasize that most medication does not want to pass through the breast milk. So for example, Ativan actually has an extremely low rate of transmission. through the breast milk. The rate of transmission is thought to be about 2%, which is much less than the 10% guideline recommended by the American Academy of Pediatrics. So people always think like, oh my gosh, if I take a sedating medication, then it's definitely going to, affect my baby. And that's actually not true actually at all. So for example, even Seroquel, if you're giving Seroquel to a patient, Seroquel also has a reassuringly low rate of transmission to the breast milk. So, so I try to counsel patients about that. And then the other thing is we try to give medications that are as short acting as possible. So this is true all the way through the perinatal period. So this is why, for example, I would much rather give Ativan than Klonopin or something longer acting. We try to go with the shortest acting medications that we possibly can. And then last thing, again, this is something that's not often emphasized, but I think is very important. In the postpartum period, especially early postpartum, the metabolism issue really, someone's metabolism really does go down by quite a bit. And so a little bit can go a long way. Someone might actually do perfectly fine with 0.25 milligrams of Ativan, and you wouldn't think that would be enough in the postpartum period, but it often is. The other thing is that I try not to give sleep aids. We as psychiatrists probably would generally shy away from those anyway, but sometimes patients will say, is it okay to take, what about Ambien? What about Lunesta? What about this, the Benadryl that I was taking? And it's not that those things are terrible. It's just that the likelihood that there's some mental health issue that's playing some role in the difficulty sleeping, whether it's anxiety or some sort of mood issue, then those medications are not going to be helping that at all. I would much rather give someone a little bit of Ativan, help their anxiety go down, and then their sleep can actually be restorative, rather than taking 10 or 15 milligrams of Ambien, which is actually not going to address their anxiety at all. And then they'd end up with polypharmacy because they're going to end up taking a bunch of different things.
Thank you.
Other thoughts, other questions?
Hi there, Jennifer Crawford. I'm one of the clinical psychologists in the audience today. So I just wanted to thank you very much for being here today. And I wondered what advice you would give for folks making that decision about hospitalization in the absence of a clear indication of intent and plan to harm oneself or the baby. Because you kind of hinted at that reluctance to share clearly.
Yeah.
Sometimes Dr. Rose and Dr. Higgins and I were sort of part of a perinatal mental health team or reproductive psychiatry team here. We talk about a waxing waning presentation that can get confusing in assessment. So what kind of advice would you have for folks who may be working in our psychiatric emergency services for thinking about that piece of it, sort of involuntary hospitalization?
Yes, it's a really great question. And some of this is a little bit context dependent because, for example, at Columbia, we actually have the ability to hold patients in an ER for up to 72 hours. So before we have to make a decision about hospitalization or not, so there can be a little bit of a bridge. So some of this is structurally dependent, but in many situations, you're trying to decide ER or home or ER or inpatient admission. What I would say is the people if you suspect postpartum psychosis, and there is a lot that supports postpartum psychosis, I would always err on the side of hospitalizing them, no matter what they say, to be honest. Because number one, it's going to be a little bit hard to have the type of cogent conversation that you want to have to be able to fully flesh out how suicidal someone is, or if they're having thoughts of harming the infant. Secondly, because this is an affective psychosis, a lot of times their judgment, insight, and impulse control are very poor. So, so for example, when I was the associate director of the women's program at Columbia, one of the things that I did is I created and ran the psychiatric consultation service for the obstetrics, inpatient obstetrics at Columbia. And I had a patient who very sadly had a full-term stillbirth. We all have to remember, of course, that just because someone doesn't have a live birth doesn't mean that they're not postpartum. So sometimes patients with pregnancy loss and stillbirth and we have to sort of remember that they are definitely in the postpartum period as well. And this patient seemed off in a way that was unusual for a stillbirth. She seemed somewhat confused. She seemed to wax and wane about what had actually happened with the stillbirth. Some of this had to do a bit with a language barrier, but not really because we had translators involved. It was a confusing presentation. I didn't quite know what to do, so we just kept her overnight. And she ended up, she did have a sitter with her, but she ended up having a very serious suicide attempt. And we think that part of that was that she was, and then she later showed herself to be very psychotic. So, you know, what I would say is these outcomes of suicide and infanticide, obviously they make the press and they are catastrophic outcomes and they can never be reversed. So if I really think, I can't think of a single time I have not hospitalized a patient with postpartum psychosis that I strongly suspected was. Because the truth is, like, again, depending on various laws in different states, the ability for them to care for themselves, the ability for them to is going to be greatly impaired. Even the chance that they will do something impulsively because of poor judgment or because of a delusional state, I would just worry about it a little bit too much. It is one of those, like, I'm not sure I'd sleep well at night type of calls. And so, again, there's a lot of reasons why someone might deny. You know, if we ask them in a very simple manner, are you suicidal? No. Do you have any thoughts of harming the baby? No. But then they're staring at the window. I would err on the side of hospitalizing.
Thank you so much, Dr. Hutner. I think we'll probably need to bring it to an end so everyone can get on to their next meeting. But appreciate you so much taking the time to speak with us.
Oh, no, thank you so much for having me. And it sounds like you guys are doing wonderful, wonderful things out there. So keep it going. This is great work that you're doing.
Thank you.
Okay, take care. Bye-bye.